This is Radio Health Journal. I'm Reed Pence. This week, police investigations in the emergency room.
As medical professionals, our first duty is to our patient, not the police or the law. That's why I'm saying you need a warrant from a judge if it was that important to you.
When trauma care and law enforcement collide, when Radio Health Journal returns.
I'm Nancy Benson, host of Radio Health Journal. If you enjoy Radio Health Journal, you'll also like our sister show. Here's a preview of what they're covering on Viewpoints this week.
This week on Viewpoints.
We live in a time when advanced medicine wards off death far better than it helps us prepare for peaceful ones.
Facing our mortality and getting our affairs in order at the end of life. Then,
right now, AI is very integrated in everybody's life. We've got Siri in our pocket. We've got Alexa on our countertops. So it's everywhere already. And this is just narrow AI. This is AI in its infancy.
The reality of AI development. I'm Marty Peterson.
And I'm Gary Price. These stories in depth this week on your public affairs magazine, Viewpoints.
Listen to Viewpoints on your favorite radio station, iTunes and Stitcher.
In October of 2017, a nurse at the University of Utah Hospital was arrested by police and dragged screaming out of the emergency room. Her crime? She refused to allow officers to draw blood from an unconscious patient who'd been involved in an accident. She was protecting the patient, who couldn't give consent, and the police had no search warrant. In this particular case, the video of the nurse's manhandling went viral. But less violent, often negotiated versions of these conflicts are not exactly rare. Dr. Sarah Jacoby is Assistant Professor of Family and Community Health at the University of Pennsylvania School of Nursing. She's studied what happens when trauma care conflicts with a police investigation.
Anytime that there's a situation that falls within the purview of both healthcare providers and law enforcement officers, there's an opportunity for conflict between whatever is considered the most pressing priority for each of those different professional sectors. And despite the fact that I think in many ways they share a responsibility to protect public health and safety. And so the things that I think are most notable examples would be emergency examples. So in the context of what I study, in response to traumatic injuries, so whether that be in the aftermath of violence, like a shooting, or even like motor vehicle crashes. Motor vehicle crashes often at least initiate response from law enforcement officers as well as at least emergency medical service providers. I think it's really in the aftermath of emergencies that might be of interest both to people interested in criminal justice and law enforcement, but also that require a medical response.
Both healthcare workers and law enforcement have public safety responsibilities, but sometimes in the emergency room, there may be a question of whose have priority.
I don't know that it's necessarily always conflict, but it's sort of definitely maybe conflict for time or for whose priority is, whose imperatives are in priority. So one would be, I guess, I would think of the example of a shooting or a violent incident. And I would imagine that from a law enforcement perspective, one of their emergent needs would be to know if the person who's hurt can give them information about any other imminent public safety threat, or perhaps another act of violence or retaliatory violence, or even in the case that the law enforcement officer might think that an injury is non-survivable. There is just a little bit of time where they might be able to get information to help them understand the context of a criminal event that caused that injury.
Let me give you an example. Person comes in, very common, driving under the influence, and they insist on us getting a blood alcohol level. Patient refused to acquiesce to that test, to agree to have it done. The police, in some instances, will ask us to forcibly restrain the patient and draw blood. Now we're getting into conflict area because there's not a medical reason to really draw a blood alcohol level, but there certainly is a legal reason.
Dr. Michael Girardi is past president of the American College of Emergency Physicians.
Us as emergency physicians and nurses say, boy, but is that really necessary to hold a person in 4-point restraints, possibly cause nerve damage by trying to get to a vessel? In our terms, sometimes I'm battering, but that's not what we're there for. We're there for making diagnoses, relieving pain, treating illnesses, and this is crossover into that gray area of law enforcement and societal needs to keep ourselves safe. So do you see the conflict?
When that happens, healthcare workers say their mandate is clear, especially when patients are in no condition to stick up for themselves.
That happens, I think, probably more often than we imagine. And I think beyond a patient being able to provide informed consent because of their injury, they're also receiving perhaps medications in the emergency department for pain that changes their ability to cognitively process what's going on. Again, they might be very terrified. They might be in a moment where they're not sure that they're going to survive an injury or an illness or something like a heart attack. And so in those moments, it's the ability to really think through giving information or interacting with individuals might be really, really difficult to protect oneself. So then it does fall on the healthcare providers in the healthcare institution to provide that protection. And I think that there definitely are circumstances where healthcare providers will advocate for the patient saying, this is not, you have to wait, this is not the time.
Invariably, we come down on the side of protecting the patient's rights, such as privacy, right to consent, non-invasive procedures, unless they're absolutely medically necessary. And when people can't consent, we'll intervene on behalf of the patient to what we think is the best thing to do at the time to stabilize them or save their life when they can't give consent. But that's all judgment, professional judgment, and therefore when you get into that realm, you really have to adhere to your professional principles, which puts the patient first. As medical professionals, our first duty is to our patient, not the police or the laws. That's why I'm saying you would need a warrant from a judge if it is that important to you. And usually when you bump it up to that level, usually the patient's more likely to acquiesce, saying, well, the judge is involved and maybe there's a warrant, but they may be intoxicated, so they may not be thinking clearly. Well, as the medical side, we're not going to take advantage of that person's intoxication and violate their right.
But what about when it's not so clear which priorities come first? Jacoby has mentioned a few. For example, when there's an imminent threat. Trauma care workers need to patch up the patient, but police need to be able to protect public safety, and they may have to intrude with questions sooner than usual.
Gang member is shot, comes in wounded, taken care of by the trauma team, somehow is surviving. What happens sometimes is they're in fact chased by the person who tried to kill them or that gang, and they try to finish the job in the ED. So these are some hazardous times. That's why we have to have a very cooperative relationship with law enforcement, because you're not just dealing with a patient, you're dealing with other entities linked to that patient.
You'd think that there would be a variety of laws, policies, and procedures to guide the presence of law enforcement in the ER, and some do exist, such as the federal HIPAA law. But Jacoby's work shows that those are not adequate.
There are policies and there are bioethical norms also that prioritize patient care in healthcare institutions, and then federal policy that, like you mentioned, like HIPAA, that protects patient privacy and personal health information. But I think that there are gray areas at the boundaries of institutions like healthcare institutions. There's also different kinds of policies that are in play when we think about patient privacy and what trauma care providers would or would not say to anybody outside of what we call like the covered entity or the healthcare institution that is regulated by HIPAA. So there's federal policy, but then there's also state policy. So some state mandate reporting to law enforcement of any act of assault, especially if police officers are not with the patient at the time that they arrive at the emergency department. So in that case, reporting is mandated, much like would be mandated in the case of suspected child abuse, for example.
Without adequate policies, police and healthcare workers have to work it out on a case-by-case basis.
They're negotiated in a rather ad hoc way that are based on municipal, regional, or even institutional norms and habits. And so I think even though you may have a policy in place, the day-to-day enactment of that policy and over time are defined by a whole lot of other aspects of institutional culture or even relationships between individual law enforcement officers and healthcare providers. It's very context dependent, but I'm sure that there are certain circumstances where clinicians don't really know what they can and can't tell a police officer, or a police officer just happens to be standing nearby where patient information is discussed. And I think those are the places that we really need to think about how policy can be enacted in order to make those kind of gray areas more explicit and less likely to be negotiated in the moment and in some sort of ad hoc fashion.
Many people are unaware that HIPAA has exceptions, so it's not an ironclad lock against having your medical records seen. For example, when criminal conduct is suspected or to avert a serious threat to public health or safety.
The police will subpoena the medical records, and they're going to end up with that information. That police officer can't walk out of there with some hearsay or, hey, I talked to Doc Girardi, and he said he thinks the patient said this. No, that's why I said you're going to have to interpret what you read from my record. And it happens very often where the prosecutors ask us to come to court to testify the veracity of what we put down in black and white and what we remember or don't remember. And that the protections of HIPAA do not protect you from a court subpoena in a criminal action.
And perhaps especially when injured people think they may be a suspect, they may not answer medical questions because they think it's the police who are asking them.
Let's take the person who had a car accident, and they may have caused the car accident and actually killed somebody. I would go up to the patient and say, well, geez, what happened? And they could think I'm the police doing a crash investigation. And many times I have to say, no, I'm just asking to try to understand the mechanism of injury, see how at risk you are for injuries I see, but also occult injuries based on how fast you were going and what the mechanism is. And patients commonly misinterpret those type of questions. They think we're doing a crash investigation, when in fact we're not. We're doing a non-pejorative assessment of how at risk they are for occult injuries or major internal organ damage from the accident.
I can say that in some of the interview-based research that I've been involved with over the years that asks seriously injured patients to recall their experience of injury and the medical care that they received, some have described not being able to differentiate or remembering not being able to differentiate the questions that were asked in service of their medical care and the questions that were asked in service of law enforcement. And it was in that immediate and often terrifying aftermath of an injury. So while I'm not sure that it has implications necessarily directly in the moment, I believe, and I think there's some research to demonstrate that it can change how patients engender trust in the healthcare system in general, or understand the boundaries between these very different kinds of institutions.
That's important because Jacoby says it's essential that in a moment of personal health crisis, patients feel the healthcare system is a safe haven.
What speaking to patients as they recall their experiences leaves me with is the profound vulnerability that they feel in those moments. If patients remember the extreme vulnerability of those first moments, of those first hours after injury, then we want them to remember it in a way in which they saw the health system as a place of safe haven and protection, and even that they saw the law enforcement officers with whom they interacted as acting in their service and not perhaps trying to question them in a moment when they couldn't really cognitively or emotionally contend with what they were going through.
Some hospitals have put in needed procedures to guide interactions between patients, healthcare personnel, and police. In the Utah hospital, where a nurse protecting a patient was arrested, police now must go through intermediaries rather than nursing staff with their request. And they're barred from patient care areas. But is that too strong a response?
It's not about necessarily always avoiding the overlap of law enforcement and health systems because, again, they share this mandate to protect people and to protect public safety. And so we have to make sure that they're able to collaborate ideally so that they can fulfill that shared mandate. So I don't know that this is necessarily always about keeping police away from emergency departments. And in many cases, probably they provide security in emergency departments. I think that they also are so essential in moments in, for example, mental health crises. So it's not about keeping police out of emergency departments per se. It's more about defining the circumstances in which those interactions will ideally protect both the patient's health first, then the patient's rights second, and then we make sure that also that clinicians and law enforcement officers have the information and the space to do the work that they need to do.
You can find out more about all of our guests through our website, radiohealthjournal.net. I'm Reed Pence.
Do you know the signs of encephalitis? Nearly 8 out of 10 people are unaware that encephalitis is inflammation of the brain, a devastating condition commonly misdiagnosed that affects 500,000 people a year. Death rates from encephalitis are high, and survivors may be left with a lifelong brain injury. This World Encephalitis Day, the Encephalitis Society is raising awareness about the risks, treatments, and preventative measures of encephalitis. According to Chief Executive Dr. Ava Easton,
most people don't know encephalitis can be a life-threatening condition caused by an ordinary infection or a person's own immune system. Symptoms vary, but can include a flu-like illness or headache, drowsiness, seizures, or the inability to speak or control movement.
So on February 22nd, wear red to show your support for World Encephalitis Day and those impacted by the disease. Find out how else to get involved at worldencephalitisday.org. That's worldencephalitisday.org. Brought to you by the Encephalitis Society.
At least 48% of all adults in the United States have some form of cardiovascular disease, according to new statistics from the American Heart Association. That's a significant increase over previous years, mostly because new guidelines mean many more people are now classified as having high blood pressure. Dr. Marielle Jessup is Chief Science and Medical Officer for the American Heart Association.
These updates are an important tool. The data have transformative power, holding us accountable and helping us chart our progress, determining if and how we need to adjust our efforts.
The report in the journal Circulation shows that cardiovascular disease remains the #1 killer of all Americans, claiming more than 840,000 lives in 2016. After decades of decline, cardiovascular disease deaths in the U.S. are once again on the rise. But there is good news as well. Smoking continues to drop, and the prevalence of physical inactivity has decreased by more than a third since 2005. Find out more at heart.org.
What are you going to do with your old car? You can try selling it, you could junk it, or you can donate it to Heritage for the Blind. Your car will be towed away for free, and your donation is tax deductible. Just call 1-800-835-1478. Heritage for the Blind accepts cars, vans, trucks, and boats. It doesn't matter if your vehicle runs or not. It will be towed away for free, and you'll be supporting those that need help. Heritage for the Blind is a nonprofit organization that helps the visually impaired live fuller lives. Call right now to donate your car, and as a special thank you, you'll receive a free 3-day vacation voucher to over 50 locations. Call Heritage for the Blind right now. Call 1-800-835-1478. Donating is easy, and your vehicle is towed away for free. Plus, you'll get a free vacation voucher for donating. Call now, 1-800-835-1478. That's 1-800-835-1478.
And that's Radio Health Journal for this week. Radio Health Journal is a production of MediaTrax Communications. Follow us on Facebook and Twitter, and check iTunes for a library of past programs. Plus, you'll always find podcasts of our segments, information about our guests, and the latest health news at radiohealthjournal.net. Join us again next week for another edition of Radio Health Journal.